because of exigencies, you'll be starting for us. So please, you have 15 minutes. And your topic is pathophysiology of heart disease in diabetes. Thank you.
Thank you for the opportunity. Dr. Vincent from University of Calabar Teaching Hospital. So I'm taking within the next 15 minutes, we are going to have an overview and insights of pathophysiology of diabetic heart disease. I think this presentation is expedient in view of the growing burden of non-communicable disease, which diabetes and hypertension ran the highest. If a World Health Organization, as a word of introduction, say have about 30 million deaths from non-communicable disease annually, and out of these deaths occurring in the low and middle income countries like ours in Africa. So it becomes very important. Many studies have been done concerning it. We all know that diabetes mellitus is a multi-systemic organ, not occurring in isolation, affecting virtually the whole organ of the body. However, today our emphasis and focus is going to be on the heart. Why is most science we talk only about the effects of hypertension on the heart, but diabetes have been discovered to have as an independent risk factor for heart diseases. And in view of the growing burden, see a projection by World Health Organization to increase, which corresponds to this year and next year, to about 27%. So the question is, most often at times, they occur not in isolation, but with systemic hypertension. And along, we are going to look why there is a close association between it and systemic hypertension, giving a double burden and a background of other comorbidities. So it becomes expedient. And diabetes mellitus, as you know, is an endocrinopathy resulting from chronic, the word there, chronic hyperglycemia, very important, critical, due to relative or absolute deficiency of insulin production or secretion, or decreased peripheral utilization of insulin, that resistance, and increased hepatic production. An international federation of diabetes recorded a global burden of diabetes with or hypertension at the rate of 8.3%, which is quite high, and projected to be 9.9 by 2030. So in Nigeria here, the natural prevalence as of 2007 is 4.04%, and the study done in Port Harcourt recorded 6.8%. And we also know that some of the following cardiovascular complications: coronary artery disease. There is something peculiar about, which we also see further in the slide, about the coronary artery disease in diabetes. One, it starts very early in life. Two, it's accelerated. Three, it's recurrent. Four, it affects coronary autoregulation. Six, it impairs collateral circulation and high level of morbidity and mortality. Other problems are left ventricular dysfunction, increased left ventricular mass, diabetes, cardiomyopathies, and leading cause of death. And so it becomes expedient for us to know what is going on in the heart for early intervention. And also, there is also, I've noticed, a loss of notional drop, which is a risk factor for cardiovascular events. Other studies have supported this, like Dabunji has shown some of the peculiar factors in isolated, in normotensive diabetes, without hypertension, have left ventricular dysfunction, increased left mass index, systolic blood pressure, all were affected. Study done by other women Nigerians. Diabetes and hypertension poses a double burden. We see why it's not a coincidence, but it's a holy synergy, increasing the problem of diabetes. We see some of the risk factors. This is a general overview. the big picture of the hyperglycemia on diabetic. It affects the heart at 7 level, at metabolic level, reducing the ATP production, cellular level, affecting the cellular structures, structural level, remodeling, functional level, systolic and functions, electrical level, chronotropic nature of the heart, and the function.
I told her to read for me the
It prevents coronary autoregulation and survival. As much, yes, that is not moving.
Professor, wait. Will you stop sharing? There's no moving. No, continue shaking. Continue talking.
It's moving. It's not moving. So some of the pathophysiology changes, coronary artery disease, also we have seen. They also have a myocardial infarction. And myocardial infarction in diabetes is peculiar. One, because of the silent nature of the infarction, increased ischemic burden. Two, because of the problem of collateral circulation, which is a survival mechanism, is lost in diabetes. Three, the loss of pre-ischemic condition. The loss of pre-ischemic condition. The loss of pre-ischemic condition, myocardial infarction, the silent nature, the frequency, and the loss of collateral circulation, which is a survival mechanism. All these are lost in diabetics. So it makes it more difficult to treat even after stenosis, after stenting, there's a problem of restenosis. Framingham was first to discover the peculiar nature, the high morbidity and mortality associated with diabetes that has myocardial infarction. And also the concept of pre-ischemic conditioning is more pronounced, is attenuated in diabetes, because before any myocardial infarction, there is regulations that try to reduce the impact of myocardial infarction. But in diabetes, the pre-ischemic condition is lost. So it makes the myocardial infarction very bad. And also in addition, they have recurrent infarction, heart failure, arrhythmias, and failure of pre-ischemic condition. We also see the problem of cardiovascular autonomic dysfunction. Here is a very major problem. Mostly, that is why you have most of diabetes having resting tachycardia, unexplained resting tachycardia, because of affectation of autonomic arm. And secondly, apart from that, during exercise, they are prone to sodium cardiac death because they had the problem of heart rate response, blood pressure response, autonomic response, and also on standing, they have postural hypertension. So these are the peculiar nature. And if you want to assess some of these, are some of the maneuver to assess the severity of autonomic dysfunction. And also currently there are new ideas because of, in diabetes, also discovered like what they have in cardiomyopathy. They have a fiber disarray because of the problem of diabetes is both at metabolic level, cellular level, structural level, functional level, in form of remodeling. So this give to new terminology of what we call diabetic cardiomyopathy, where there may be both affectation of the systolic function and the diastolic function because of alterations. So the microangiopathy, which is general, and also is essentially in the presence of hypertension, is 5-year study showing the double burden of diabetes and hypertension. Not a coincidence, but you will see some of the changes hypertension heart disease. Most often than not, most of diabetes will come with hypertension. And these are some of the changes that are peculiar in diabetes: overactivation of the sympathetic nervous system, activation of the RAS system, salt and sodium water retention, vascular compliance, elevated endothelium level, loss of deepening nocturnal blood pattern, increased free fatty acid, and a powerful risk factor for nephropathy. All these make increase the presence of hypertension in diabetes, and this increase the morbidity and mortality. And all this is also reflected in the functional level, affecting the heart, the diastolic function, the proper power of realization, and diastolic volume, which eventually, in the presence of preserved ejection fraction, the output is low because of reduced end diastolic volume. And in addition, they still have reduced systolic function, making it the heart failure more refractory and more difficult to treat, and reducing the quality of life. And also have congestive cardiac failure, and incidence of sodium cardiac death is quite high compared to other risk factors. It's just an overview of the general mechanism of diabetes, of what goes background. And we also had a phenomenon of what they call diabetic paradox. Before somebody becomes clinically diabetic, the person, a lot of changes have gone at the level of metabolic level, cellular level, structural level, functional level, autonomic and electrical level. And these are some of the changes that lead to the pathophysiology. There is a formation of advanced glycated end products, which is a pro-inflammatory pathways, and increase free radicals and injury to the cells, both endothelial cells and the property of realization. We also have sorbitol pathway. Sorbitol pathway, because heart is highly energy dependent system. It requires so much ATP, which is help in patient survival, increased demand during exercise tolerance. But in the presence of diabetes, the redox potential reduced and ATP production, both the quantity and the lifespan of the ATP, they reduce. So the energy level of the heart, they reduce. It made them to cope with exercise tolerance, stress, because of in the presence of chronic hyperglycemia. And these are the metabolic changes that happen. Reducing, and also formation of diacylglycerol. And this diacylglycerol, we are seeing, this affects the diastolic function because of increase in production of abnormal collagen expressions, and also endothelial cells affecting vascular flow, vascular permeability, and pro-inflammatory nature of gene expressions. So it becomes expedient to have a further insight into what is going to. It's not just exosamine pathway, also affecting the heart at every level, both the realization property, and much more importantly, the nitric oxide system of the coronary circulation is affected, the quantity production, the quality of production, the duration of action when the exosamine pathway is activated in the presence of chronic hyperglycemia. And this overall impel the function of the heart, impel the efficiency of the heart, and lead to possible sodium cardiac death, electrical dysfunction, and autonomic malfunctioning. This is a unifying mechanism of hyperglycemia and cellular damage. As I said earlier, this is a Framingham study, first striking revelation, when they noticed they do 5 years of 5 study and discovered that the mortality and morbidity in diabetes were high. That made them look for that, what could be peculiar about the diabetes.
Dr. Ego has 1 minute more. 1 minute to go.
So this is summary, endothelial dysfunction. In the heart, this will lead to endothelial dysfunction, peculiar to heart, autonomic dysfunction, metabolic derangement, reducing ATP production, and fibrosis, This affects diastolic function, systolic function, remodeling. In conclusion, in view of the high mortality, high morbidity and mortality associated with diabetic heart, it becomes expedient for early and comprehensive evaluation of diabetes with reference to the heart for optimal management of diabetes so that it can improve both the quality and the quantity of life. Thanks you for listening.
Okay.